And you have truly been a trailblazer in this field, and it's a pleasure to have known you and worked with you alongside you. So thank you. All right, and I would like to thank Dr. Rania as well as the program committee here and Dr. Fauzi for inviting me to speak to you about something different, a little bit different. This is postoperative imaging and complications after pelvic floor repair. I have two lectures. One is going to be the anterior compartment repair, and then the second one is going to be the apical and posterior compartment repair. So let's start with this one. I have no pertinent disclosures. As Rania mentioned, her and I have worked together at the Society of Abdominal Radiology Pelvic Floor Disease Focus Panel, and again, it's been a pleasure to work with her there. So the objectives of today's talk are to introduce to you what type of procedures are used for repair of anterior compartment dysfunction in the pelvic floor, talk about what pelvic floor imaging techniques we use to evaluate these patients, show you what the expected appearance of these post-surgical patients is, and where to look for the different types of post-surgical materials, and then show you some examples of complications. So pelvic floor dysfunction, as many of you may know, is a set of multiple different disorders, including pelvic organ prolapse, urinary incontinence, pelvic pain, constipation, fecal incontinence, that all together are called pelvic floor dysfunction. In the US, this has been reported to affect nearly 1 out of every 4 women in the US age over 20. So it's a pretty common disease. The risk of surgery is 11% by the age of 80. Again, so 11% of patients with pelvic floor dysfunction have some kind of surgical procedure done by the age of 80. Unfortunately, many of them have a repeat procedure done. So the rate of reoperation or a second procedure has been reported to be almost as high as 30%. That's a lot. Why is that? Well, it's maybe because before they do the first procedure, there was inadequate evaluation and the extent of the pelvic floor dysfunction was unknown, but it could also be because after the initial repair, there was some kind of dysfunction of the repair, and that's what we're going to focus on today. So thinking about what type of pelvic floor surgical procedures are available, this can be divided into the anterior compartment, apical or middle compartment, and the posterior compartment. For this first talk, I'm going to focus on the anterior compartment. So the main disorders in the anterior compartment are stress urinary incontinence and pelvic organ prolapse. The stress urinary incontinence includes, the surgical procedures include urethral bulking agents, pubovaginal slings, synthetic mid-urethral slings. There's different types of those, such as the retropubic, transobturator, and single incision slings. And then for pelvic organ prolapse, there's a number of different repair procedures. For this first talk, we'll focus on the two things in red, which are the bulking agents and the mid-urethral slings. For the pelvic organ prolapse, the transvaginal mesh, I will discuss that in the second lecture. All right, so you may wonder, what are some of the imaging indications when these patients present after surgery? Usually, these patients have had surgery at a different institution, or they've had multiple prior surgeries, and the history is not well known. So imaging is used to find out what surgery has been done in the patient. These patients may also present with pain or other complications, so imaging is used to see what complication is present. And finally, when the surgeon decides to go resect these materials, then the imaging can provide a surgical roadmap. And you may ask, well, how do we image these patients? There's two main modalities we use: ultrasound and MRI. So I'm very glad that Professor Ola went before me and showed you how to do the ultrasound. I'll do a very brief show and tell of how to do just a transperineal or translabial ultrasound. So as Dr. Ola showed earlier, the probe is placed at the level of the perineum. This is a sagittal orientation, and this is the transverse orientation. So you can see this on this schematic illustration. This is the pubic symphysis, bladder, uterus, and rectum. On this transverse view, we're at the level of the urethra, and this is the bladder. So if we were to orient this, how the images look like, so if I turn this image upside down, this is how we orient our images. We focus the anatomy just in this section, so we're going to be looking at the urethra and the bladder and the vagina mainly. And so when we blow up that image, this is the pubic symphysis, this is the urethra, this is the bladder, this is the vagina, and this is the rectum back here. So that's the orientation that we use in our institute for evaluation of transperineal ultrasound images. How about on the transverse plane? So again, we're focusing on just this small part of the anatomy, and if we blow it up, here is the urethra and this is the bladder there. So again, that's the anatomy you need to be aware of for the transperineal ultrasound. How about the MRI? So for our pelvic mesh protocol is what we call it for MRI. We start with axial, coronal, and sagittal T2 weighted images. We do a sagittal T2 weighted image with fat suppression. You can do this in any plane. We choose to do it in the sagittal plane because it's a faster acquisition than the axial plane. Then we do a 3D axial T2. So the top row here is all 2D, two-dimensional. We do a three-dimensional axial T2 weighted image, and this is done at very, very thin section, 1 to 2 millimeter, and it's an isometric acquisition. So what that means is you can reconstruct this in any plane with relatively good resolution. And then we do axial T1 weighted in and out of phase images. The in-phase images with the long time to echo, TE, allow us to see blooming artifact in areas of prior surgery. And then we do pre and post contrast T1 weighted fat suppressed images showing areas of inflammation better. And I'll show you examples of cases that use all of these sequences. So before we start and show the actual surgical materials, let's talk about the pertinent pelvic floor anatomy. And this has already been shown nicely, but just a quick review. So the first thing I'll point out to you is that this is axial T2 weighted image, sagittal T2 weighted image, and these two are coronal T2 weighted images. The target shaped structure here in the anterior portion of the pelvic floor hiatus is the urethra. On the axial image, on the sagittal image, you can see it's this kind of almost a cylindrical tubular structure extending from the bladder to the perineum, and here it is on the coronal image. Behind that is this H or butterfly shape appearance on the axial image of the vagina, and you can see the vagina on the sagittal as well as the coronal image here. Posterior to that is this the rectum and the anal canal. Here you can see this is from an MR defecography, so the patient had ultrasound gel put in the rectum. So you can see that both in the axial and sagittal images. And then the urogenital hiatus is bordered by the levator muscle, specifically the puborectalis muscle here. This is a very important landmark for us to evaluate when looking for surgical materials in the pelvic floor. Another very important landmark is the retropubic fat. So this fat here, just anterior to the periurethral ligament, is the retropubic fat. You can see on the axial image. On the sagittal image, you can see the fat between the pubic bone and the bladder. Very important space. Always evaluate this space for looking for urethral sling material. And on the coronal image, you can see again the fat between the bladder and the muscle, and the levator muscle is very important to evaluate. So the key here is it's very important to know the anatomy and to look in specific regions for areas of prior surgery. Okay, let's start with the first surgical material. This is urethral bulking agent. Okay, so this is synthetic material which is injected into the urethral wall. It's injected within the spongiform tissue of the urethra, as shown on this image, on this illustration here. So this is the needle. It's done transurethral. It's injected in the urethral wall, and it improves the coaptation of the urethral mucosa. And so what it does is it prevents incontinence because the mucosa is coapted better. There's various different products that have been used. I'm not going to go into specific products here, but just so you know, there's different products and they're made from different synthetic materials. The most common one is a silicone polymer. So what does this look like on MRI? So here's an example of an MRI of a normal urethra. This is, again, as I showed you, the target shape on the axial image of the urethra. This is the sagittal image of the urethra. This is the coronal image of the urethra. No bulking agent on this patient. This patient, on the other hand, does have bulking agent. You can see this round structure, how the urethra is enlarged and has higher signal intensity on the T2 weighted images. On the sagittal as well, looks like there's bulging anteriorly and posteriorly. Almost looks like a prostate gland in the female patient, but of course it's not a prostate. This is what urethral bulking agent should normally look like. And then on the coronal image, again, you can see the bulging of the outer wall of the urethra because of the installation of bulking agent surrounding the central lumen of the urethra. So this is what it should normally look like. Often it's high signal intensity on T2, and it should be circumferential around the urethral lumen. When you give contrast, it should not enhance because it's synthetic material. unfortunately, it can often look like a urethral diverticulum. So that is a pitfall you have to worry about when you look at this. Is it a urethral diverticulum or is it a bulking agent? And then whenever you see something that doesn't look quite as bright as fluid, it may have a slightly odd shape to it, and now you don't see a neck coming from the urethral lumen, you check the history, it actually may be bulking agent and not a urethral diverticulum. And I know I mentioned that oftentimes it's bright on T2 weighted images, but depending on the specific product used, it can calcify and actually be dark on T2 as well. How about on ultrasound? So here is patient number 1. This is a normal urethra on ultrasound. There is no bulking agent in this urethra. Patient number 2, same sagittal orientation. This is the urethra, and then all of a sudden you see this very echogenic round globular material. This is bulking agent, specifically silicone bulking agent in the urethra. On the transverse ultrasound image, this is a urethra, and again you see the same patient. You see this globular, very echogenic structure. This is bulking agent in the urethral wall. If we were to draw a line through this part and do an axial reconstruction, you can see this is the urethra, this is the lumen in the center, and this echogenic material around the lumen is the bulking agent. This is what it should look like. We can do these volume reconstructions that our surgeons like, and as Dr. Ola said, they haven't been shown to add that much except pretty pictures and something that the surgeons do like. But this is what it would look like. This is the central urethral lumen, and this is the expanded wall of the urethra because of the bulking agent. How about a different patient? So this is a different patient, and you can see I'm going to draw a circumference around what the urethra is. All right, so this is the lumen centrally. This is the urethra, and now you can see that there's bulking agent on the patient's right side of the urethra, but instead of being in the wall, it actually has gone outside the urethra. So this is actually migration of the bulking agent into the periurethral tissue. So this is not normal, okay? The normal should look like this in the circumference around the urethral lumen. This is abnormal where it's gone outside the urethra. On MRI, here is a sagittal image of the bulking agent. You can see, again, looks almost like a prostate in the female patient, but you can see the anterior and posterior components. The lumen is in the center. On the axial image, here it is. The lumen is in the center, but if you look carefully, there's actually some additional material outside the urethra. On the coronal image you can see here, this is supposed to be all contained within the urethra here, but it is extending out, and it's extending out into the bladder neck. So this is also migration. This is what migration looks like on MRI. So again, it should all be within the wall of the urethra, but it has migrated out into the bladder neck. All right, so that was the part on bulking agents. To summarize, you're looking for material that is echogenic on ultrasound and usually high signal intensity on T2. It should be injected circumferentially around the urethral lumen. Some of the complications include migration, as I've shown here. You can have recurrent incontinence if the volume of the bulking agent decreases over time. If there's too much bulking agent, patients can come with voiding dysfunction and inability to void, and then can also present with infection. And as I showed you here, this can be evaluated with both ultrasound or MRI. So this is the summary slide for bulking agents. We will move on to the urethral slings. So urethral slings are also an option for treatment of urinary incontinence. So what they are, it's a polypropylene mesh ribbon. It looks like this. This is just from one particular brand I took from the internet. There's multiple different brands, but this is what it looks like. And it's placed to support the back wall of the urethra, almost like a hammock. And so it supports the back wall of the urethra, and I'll show you these images here. You can see this is the ribbon of the mesh that is placed. In this particular case, the mesh is placed supporting the back wall of the urethra, and the arms are going behind the pubic bone, between the pubic bone and the bladder, into the retropubic fat. So this is a retropubic type of sling. This, on the other hand, you can see, again, it's supporting the back wall of the urethra, but instead of going anterior, the arms are going lateral into the obturator foramen. So this is a transobturator type of sling. So again, this is just a movie showing you what this retropubic sling looks like. You can see how it's going between the pubic bone and the bladder. And then this is the transobturator sling, where the sling is going through the obturator foramen and not anteriorly between the pubic bone and the bladder. So on ultrasound, this should be at the level of the mid-urethra. So this is a transperineal ultrasound. This is the urethra. And this echogenic line here in the midline is the sling, okay? It can be hard to see, but you're looking for something like an echogenic line that is parallel to the wall of the urethra in the midline. It should be echogenic, and it should cause this shadowing because of artifact from the sound beams not being able to pass through the synthetic material. If you look in the parasagittal plane, either left or right, we actually see more of that ribbon-like crosshatch appearance of what the sling looks like. So this, you can see how this pattern, you can actually see this on the ultrasound, and that's how you know for sure this is a sling material. Again, you can see this here on the coronal image along the back wall of the urethra. When you turn on the color or power Doppler, you're not going to see any flow in there because this is synthetic material. On these reconstructions, you can actually measure the distance from the sling to the center of the urethra, and it should be about 3 to 5 millimeters for adequate placement. So this is a static image that I showed you with the sling, and this is the shadowing from the sling on the urethra. Let me show you the cine clip, and it's much easier to appreciate in the cine clip. So here it is. This is that ribbon. You can actually see the pattern of the ribbon here. That's how you know for sure it's a sling. Here's the urethra in the midline, and there's the sling along the back wall of the urethra. And then as you go off to the other side, again, you can see it passing around the urethra. So the cine images really show it better than just the static images. So I'd encourage everybody to look at the cine images. When we do 3D recons, we can see very nice images. Again, our surgeons like these images because it shows the orientation of the sling to the urethra. You can see these sling arms are going anteriorly into the retropubic space, so this is a retropubic sling. This one, the sling arms are going more lateral instead of going anterior, so this is more of the transobturator type of sling. So on MRI, again, we're looking for the sling material. You see this dark band that's hypointense on T2 going into the retropubic space. This is the urethra, and as it's going anterior and superior, you can see this between the pubic bone and the bladder. And as it goes even higher, you can see the sling going through the rectus fascia on either side. This is the normal appearance. On the coronal image, also you can see it between the bladder and the pubic bone. This is the sling on the left side. This is the sling on the right side. You always want to look for the fat between the sling and the bladder. On the sagittal image is where I see it most commonly. You see this linear structure, again, between the pubic bone and the bladder. You always want to make sure there's enough fat between the bladder and the sling. So complications of retropubic and transobturator slings, include extrusion. Exposure is the most feared complication. It's more common with retropubic slings. Groin pain is more common with the transobturator slings. So here's an MRI showing a normal arm on the left side of the sling, but on the right side you can see this is stuck on the bladder. The bladder is thickened on the axial image, and also on the sagittal image you can see how it's tethering to the bladder, causing thickening of the bladder. On the coronal image, you can see how asymmetric it is. The left side is normal, the right side is elevated, and it's actually gone inside the bladder. This is erosion of sling into the bladder. These can also get infected. So this is a transobturator sling where the sling is going laterally through the obturator foramen. It's not going anteriorly into the retropubic fat. And the reason this is high signal intensity on T2 is because of infection. It should normally not be high signal intensity on T2, and you can see this here again going through the obturator muscle there. On the post-contrast images, you can see how it's enhancing very avidly, and this is because this transobturator sling is infected. Okay, again, just for comparison, a normal retropubic sling would be going anteriorly, and normal sling will be low signal intensity on T2. So comparing ultrasound and MRI, on ultrasound, you're looking for something that's echogenic and has shadowing. Ultrasound is the best to look for the sling between the urethra and the vagina. You're looking for that crosshatch ribbon-like appearance. On the MRI, it's better for evaluating the retropubic location of the split sling between the pubic bone and the bladder, as well as the suprapubic components. A pitfall is scarring can look very similar on MRI as the sling. So again, just to summarize, we're looking for these thin strips that are low signal intensity on T2 between the pubic bone and the bladder on MRI, and between the urethra and the vagina on the ultrasound, and always look for that crosshatch type appearance. So to summarize this first lecture, we talked about repair of stress urinary incontinence, including bulking agents injected in the wall of the urethra like this, as well as urethral slings, which can be either retropubic or transobturator, and these can be evaluated with either ultrasound or MRI. Complications include migration, exposure, extrusion, infection, voiding dysfunction, or recurrent incontinence. That's all for this first talk. Again, thank you so much to Rania for inviting me. And I'll take any questions now or is it later for questions?
Yes.
Later for questions. Okay, thank you.
Thank you, Gaurav. I was wondering how long would any radiologist take to get experience in postoperative? Does it need a lot of time? It's very difficult.
So your question was, how long does it take to get comfortable with imaging of these? I'm still learning. I've been doing it for 12 years. I think the key is taking small steps. The most important part is knowing the anatomy and knowing where to look.
Okay.
For example, if you always, on every pelvic floor MRI, the first thing I do, I teach my residents is look between the pubic bone and the bladder. Because that's where you will see the retropubic sling every time. So look in that space, look on the sagittal image, look in the coronal image. That's where it's easiest to see. And then I always look also for the apical and posterior mesh, and I'll show you in the next lecture, going from the sacral promontory to the vaginal apex, and then also in the ischial-rectal fossa. If you can look in those three places, 90% of cases you'll find it on the MRI. Ultrasound is a little bit more trickier because it requires training of the technologist as well.
Okay, thank you very much. We can have like 5 minutes at the end of the session if